So I'm going to show you two mini cases, both carotids, and like any other complications, kind of where you think through things along the way. Here are my disclosures. Nobody wants to claim these complications. So case one, 71-year-old guy, severe coronary disease, multiple MIs, including recently, low EF, defibrillator, 3 real deal right hemispheric TIA events on dual antiplatelet therapy, the following velocities, and was referred. I saw him in consultation, and we brought him in for angiograms and stent. Here you see his defibrillator, and you also see a type 2 to 3 arch and a rotated bifurcation with your tight disease on the right. Here's an innominate, and again, you can see rotated bifurcation and tight lesion. And we did the simple, roadmap, go up into the external and take your catheter up. And you can see that a very severe stenosis here and also severe redundancy up here. Now I would use proximal protection for every one of these cases, regardless of their collateral circulation. This was about 2006 before that, okay? So we're gonna do the case, and this is using the shortest distal protection, which is the AngioGuard, and we wire it on the roadmap and keep it right before this area of severe redundancy, okay? Deploy it here, right exactly where we want it, and we're pretty happy so far. So it's deployed here. Anytime you see somebody panning like this, you know there's a problem, and here lies the problem. See that line right there? I'll show you what that line is in a moment. It's this. Anybody who's used the AngioGuard, I deployed this, and it literally snapped in my hand. So now you've got the delivery catheter from the AngioGuard halfway up your guiding catheter, not attached to the other end, which is firmly attached in my hands. So the wheels have come off here, and now what? You got to have a soft landing here. And remember what you've got. You've got an AngioGuard right below a redundancy and right above a 95% symptomatic lesion. Any quick thoughts on what to do? Should I just pull hard? That's a bad answer. I'm not licensed to do endarterectomies. So what we thought about for a moment, the guy's completely asymptomatic. So what we decided to do, you can't snare it, because if you snare it, you're going to pull for sure the wire down in the basket. So what we did, I said, well, all I could think of to do is to take the balloon that I was going to use anyhow, put it on the end of the wire, and try to engage that piece that was on the wire between the AngioGuard and within the catheter. So under fluoro, we put the balloon on and slowly pushed it up, holding tension on the wire, and pushed forward on the balloon and watched it engage it. So then once we got it up there, we used the delivery catheter as a recovery catheter. So simply pushed forward on the balloon, backward on the wire, and then pulled them all back together, removing this device. This we'll call the modified Metzger recovery catheter. I've not yet to sell a single device. So what are we going to do now? Well, we got to get back on that horse. He still needed fixed. So we got a newer device and did the same thing. Carefully wired it here, put it in that same place I just showed you with distal protection balloon with a 4030. This is actually a 10 by 30 stent. This was in the Sapphire WW trial. Post-dilatation. We're not quite done with, so here's a nice result. You can see the basket right before the redundancy. And a little more adventure, had a little trouble with the recovery catheter. The simple thing to do is not push hard, but you can see if you just do simple neck rotations, it will usually free it up. And case number 1 had a happy ending. All right?
Chris, quick question for you.
Absolutely.
Why do you think it broke?
I tell you what, Jim, we put 400 in that trial. I had one break. I have no idea. It was me. It wasn't a fellow I can blame. It was me. And I was just pulling out, and without, and I wasn't in a hurry. I do these very methodically. I have no idea. I wish it wouldn't have, but it did.
And have you, if that redundancy would have been a little bit more proximal, it obviously would have been an issue without flow reversal. Have you tried the spider and just go through the redundancy and then?
I think personally, my opinion is it's a tragic mistake to go up and down through a severe redundancy. I think you should ask yourself 20 times why you're doing it, ask 25 times why there can't be an endarterectomy case. You should not go around redundancy. I think proximal protection obviates that problem as long as your stent doesn't go. But I would never go through that redundancy.
So that tortuosity and redundancy, when you straighten that out and you put a stent in, you can actually send that kink further, and then you put a second stent in and you send it further, and you can actually keep going. Now, I've never done that. I've seen others do it, but you can send that kink all the way up to the terminal ICA. So today, like proximal protection, like Chris is talking about, is, you know, the clear method of choice for this. But the important thing is if you make a pseudo lesion and you do use distal protection, you need to make certain that your stent is proximal enough that you don't deploy it anywhere near the pseudo lesion that you create by straightening that out. And it can be done by making a pseudo lesion and straightening it out, but I don't recommend that. I don't like it. You can dissect it, etc.
Yeah, and the take-home message is you don't do buddy wires, things like that. You just don't want to over-manipulate things like that. That's a take-home message, I think. All right, one more fun. You watch me getting a little more fun with carotids here. All right, this lady's delightful, 85. Anybody in this auditorium would take her as their grandmother. Severe rheumatoid arthritis, steroids, a bunch of surgeries and deformities. This was a pre-TAVR, severe stenosis with no AVR. She weighed all of 81 pounds with creatinine at 2.2. She had 5 of the real deal left hemispheric TIAs and had the following velocities. And again, a sweetheart of a lady. This shows you this condition of her hip, condition of her peripheral vascular disease, and probably the marital status of our tech. Here's her arch. If there's such thing as a type 4 arch, this would be it. That's the left subclavian. Okay, you don't see the left common. It's either a nominate or behind here. Okay. Here's the nominate, so it's not bovine. All right. Here's with a VTEC in the left common. You can see the tortuosity, and you can see the severe lesion and the reason for her symptoms and some disease in her external carotid as well. So with a catheter in place and a roadmap, we wired very carefully with a glide wire deep into the external carotid. Again, already on the Angiomax, already with a shuttle sheath in, already with a VTEC catheter, engage this. Slowly take the VTEC catheter up into the external carotid here. And then slowly telescope the shuttle. Again, she weighed 81 pounds and had peripheral vascular disease. I was trying to stay small. So we go up with the shuttle, and it's going very nicely. I'm starting to get happy. Here's a guide. You can see I'm in pretty good position. And here's that tight lesion. Hey, now it's pretty straightforward. So here's wiring it with the bare wire and putting an embo shield up here. And pre-dilatation, I'm already calling for the next carotid patient. Except, whoops, you see me sending the wire up here. Why? As I'm going up with a stent, it starts to come back. So you remember that arch that we looked at. So I see that, and I'm going to be smart. I'm going to watch both ends. I'm going to slowly take the stent back. And I'm watching down here, and I'm watching up here, and I'm going oh so slow. Yeah, well, I went slow and still prolapsed. And you've got the basket above that symptomatic lesion and your shuttle sheath down here. That's not good either. And so we slowly tried to take the slack out. Now what? I've run into this a couple of times. Again, this was mine. I've had one where a fellow visiting did this, but it was different. It was a better arch, and I could just take a neurodiagnostic catheter and a glide wire up and take it back up, and you're all good. Remember, this you saw that arch. It was not easy to get into at all. We're still above the lesion, and we're still down here. So we're taking the slack out, thinking what to do, and thought, you know, I want to get that thing out. And what we did was take a bent tip retrieval device from Boston Scientific, slowly up and around. You can see it going around here. So I'm keeping it here with no slack and watching very carefully a bent tip retrieval device go up. Here's the bent tip retrieval, taking it out. I can tell you from experience, folks, the bent tip retrieval will work with everybody's system, despite the fact that it's not on the IFU. So here's that NAV6 coming down into the aorta. And something here comes into the sheath. So now, again, we got to get back and finish the job here. This time, went up to an 8 French. This is a CBL modified guide, a VTEC. We made a road map from down here with everything in position. Again, put the wire deep into the external carotid artery glide wire. Here's the VTEC. Here's a guiding catheter going up carefully. You can notice that we had done some work with the angioplasty and everything was intact. So now it's a matter of putting our distal protection back up, stenting it, in this case with a 9x7x30, post-dilating it. Here's our angiograms with the protection system where it ought to be, and final angiograms. And here, final cerebral angiograms look good. And now we're going to take the guide out electively over a guide wire while they're aspirating instead of it coming out on its own. The only complication was to the shorts I was wearing, but they cleaned up nicely with a little shout and bleach the next day. The doctor went home that night just fine, and more importantly, the patient went home the next morning and did fine. A couple lessons learned. You, the operator, must remain calm and not scare this wide-awake patient by hearing them. You can't let explicatives go and start screaming, and you can't scare your staff. You got to stay in control and think. Literally, our staff thinks with me on this, and they gave good suggestions here. You have to assess both of those patients were completely stable, completely. And this is no knock to the surgeons on the board here. What I mean by this is don't call the surgeons immediately unless there's an emergent situation that requires them. We have some great surgical colleagues, but they come attached to surgical staff and anesthesia staff, so they're going to come buzzing around like flies while you're trying to think through things. If you need them, call them. If you have a good patient, say, hey, I'm thinking about this, think ahead, but think through it and see what you can do, and then call them when you need them. And for severely angulated arches, consider guides or today proximal protection. Proximal protection is a fantastic anchor. It will not prolapse, and you've got to watch both ends no matter what you do. So thank you for your attention, and be happy to field any comments or questions.